My name is Megan Smith, and I'm the Executive Director of Quality and Training at HRG. And I am pleased to present to the group today a comprehensive review of price transparency. So we have a lot of content to go through today. But I promise it's going to be enough information in case you missed some during the presentation. We'll have enough information packed into the slide deck that you'll be able to use that as a reference going forward. So let's jump right in. So here's our agenda for today. We're going to take a look at some of the regulations, basically what is required. We're going to talk about some strategies for how to select shoppable services, hopefully give you guys a couple of hints to make that a little bit easier. Reporting risk areas. So what are some areas you're doing your best, you're trying to pull that information. What are some things that could trip you up along the way? And then we're going to dig into kind of the CMS's current response for non-compliance. And we've seen quite a bit of activity starting in April on how CMS is going to handle that and really how that compares to what we initially thought CMS was going to be doing back in the December, January kind of time frame. And then, believe it or not, there is a silver lining to price transparency. So we're going to dig into that a little bit too. So why are we even talking about price transparency? Okay, it went live January 1st of this year. It should be an old hat by now. But if you look here, Health Affairs, they did an article for Q1, actually just a couple of months in 2021, and they noticed that it was a 35 or less than 35% compliance. So there has been some time for hospitals to prepare or organizations to prepare for this change, but a lot of folks haven't even put it into live yet. So what they did is they took a look at the top largest hospitals, 100 of them, and they just did a simple poll to see how many of them had the requirements that CMS laid out. And like I said, less than 35% were compliant. So 12 out of the 65 that they did find, 65 of them found they did some sort of compliance to this rule, but 12 out of them had no posted files, no links, there was no database, and things that they did provide, if there was something on there, you couldn't download it, which is one of the requirements. And then 53 out of the 65 did not have payer-specific rates or really didn't actually associate any of the rates with the payers, which is one of those requirements as well. So why do we do this? So we do this because Medicare feels like we need to add more transparency, and the government feels we need to add more transparency to patients. They need to have more options. So a poll that went out from Change Healthcare noticed that 53% of consumers have avoided seeking healthcare because they don't know how much it's going to cost. 67% of patients want to shop for their healthcare. They want to look at it online. They want to be able to get all that information without having to pick up a phone or go in and see somebody to see how much it's going to cost. 61% of patients said that their health care is more complex than a mortgage payment. So knowing all the ins and outs, and I don't know about you, but if you ever go to a family gathering and word gets out that you work in revenue cycle or you work in the billing office at a hospital, you got family members coming out of the woodwork saying, hey, I got this bill the other day. It is complex. We have the advantage of being in revenue cycle, being in this world, and so it makes more sense to us. But just kind of your layman person getting an EOB, it is complicated. And then lastly, 60% of patients have gone to an appointment without even knowing if they could afford it, which is scary. So let's dig back into a little bit of history here. So the Public Health Services Act, that is defined as an act that's meant to consolidate and revise the laws that relate to any public health service. So it was enacted way back on July 1st of 1944. It includes things like family planning, our ever so famous HIPAA that came out in 1996, and the Patient Protection and Affordable Care Act. So on November 15th, 2019, CMS finalized the expanded interpretation of the Section 2718 of the Public Service Act. Now, why is this important to know? Well, because way back in the day, we had to provide, and I say way back in the day, anecdotally, really, it was just a couple years ago, they pushed out that the hospitals are required to send out a list that includes gross charges, negotiated charges, a self-pay walk-in rate, minimum and maximum negotiated charge, and this list must be publicly available in a machine-readable format, which is what we know today as our price transparency. But publicly displaying our charges, that's not new. Because if you think back to the charge master mandate that happened, we have been providing information on our websites regarding to charges, but this kind of took it a step further. So the charge master requirement goal was to ensure price transparency and empower patients and payers to select more affordable services with the hopes that this would put downward pressure on hospital prices. The Journal of American Medical Association found that 51% of organizations were not even compliant with the charge master requirement that came out back in 2019. A lot of charge masters did not include or did not list machine readable information, and there were several organizations that had broken links or incorrectly linked files. So if the patient went out to look for this information, they were sent on a wild goose chase and were not able to get the information they were looking for. So as a response to the price transparency requirement, the American Hospital Association attempted to block this ruling on behalf of its 5,000 member hospitals. The AHA and other groups complained this rule creates a major burden on hospitals to put together this list, to make it machine readable, to be able to have to show their cards on negotiated rates. Unfortunately, on June 23rd of last year, the federal judge ruled against this lawsuit. And then, as you guys probably know, back in late December of last year, the AHA took it a step further. They are appealing, by the way, but they also sent a letter to the Biden-Harris Transition Office requesting that we need to look at this again and to use discretion with respect to compliance to this price transparency final rule. The HFMA also jumped on the bandwagon and filed a amicus brief on July 24th, 2020 that supported the AHA's appeal, citing meaningful patient information includes out-of-pocket costs, not gross charges. So if the point of doing price transparency is to inform the patients and allow them to make decisions on where they want their health care based on an out-of-pocket cost, then this price transparency rule does not fit the bill, because they are looking for, or they're listing gross charges and not what that individual out-of-pocket cost is. And more importantly, the term of charges and prices are distinct and cannot be used interchangeably, which if you look at the price transparency documentation and articles, you'll see that charges and prices really are used as a term interchangeably, which is concerning. So some of HFMA's key arguments was the rule is inconsistent with that section 2718 that we just talked about. It really overburdens hospitals and honestly provides no clear benefit. Less burdensome alternatives are available, patient estimates, and there's other tools that are out there that HFMA did provide. And at the end of the day, it does not achieve the goal of providing relevant pricing information to the consumer. Unfortunately, we had a federal ruling back on December 29th of last year that said, nope, price transparency is going to move forward as planned January 1st of this year. They cited the AHA failed to dispute the government has a legitimate interest in promoting price transparency and lowering healthcare costs. Charge master requirement has not helped, so that initial charge master discussion we had in the first couple of slides did not give enough information to the consumers, and evidence was clear that consumers are frustrated with the status quo. So now let's dip into some of these regulations. So who is required to comply with price transparency? So this is any facilities that are licensed as hospitals, which does include critical access. Physician services for employed physicians are required to comply with price transparency. Separate offsite locations, if the prices are different, they must be looped in on that front homepage or wherever the price transparency information is being listed for that organization. Individual items, services, and service packages in connection with an inpatient admission or outpatient department visit, if a standard charge has been established, must also be included and is required to comply. Federally owned or operated hospitals, and that's your IHS, your VA, your Department of Defense, are considered in compliance already. And that's because the charges are non-negotiable and they are provided public and in advance of the service. So where should this information be posted? Data sets must be displayed prominently on the website. So not 3 clicks in, they're saying it has to be right up front, or at least a link right up front in order to get you there. Must be publicly available on the website using the CMS naming convention, and that's making sure that everything is standardized, that the beneficiaries, that the patients can go out and they can get used to seeing those keywords and be able to shop quickly. They must be free of charge. Your files must be free of charge, easily accessible, and cannot require an account login or password to get to that information. You must be able to search digitally without providing any personal information, so strictly looking up a different type of procedure without listing all of your personal information, insurance information, things like that. And all data must be updated annually, and you have to publish the last date that it was updated. And that tells the consumers that this is the most up-to-date information that you have. So what? Publicly available. So there's two different types of files that we need to have available out on our websites here. The first is a available all service data set. So that one has to be your machine readable charge master listing. So this is like that charge master listing that we had out there since 2019, but on steroids. You got to have your gross charges, your negotiated rates. You have to include a self-pay walk-in rate for those patients that don't have insurance. You have to have a minimum and a maximum negotiated rate for all payers. And remember, we have to clearly designate which payer for that negotiated rate. It can't just say, what that rate is without tying it to, is it your Blues? Is it a, United Healthcare, for example? The second list that you have to have is a shoppable service data set. Now, this is a little bit smaller scale, which is good. It is a list of 300 shoppable services. So when you think about shoppable services, it's just that. We're doing a search, we're looking for something in particular, like a colonoscopy. I should be able to do almost like a Google search, pop it into that website, and your hospital website should be able to tell me a colonoscopy is going to cost this much. CMS has imposed that there are 70 services that are required. So at minimum, you have to have these 70 services, but the full requirement is 300. If you don't have 300 shoppable services, we'll get into that in a little bit. There are some steps that you can take. And like I said, it has to be searchable and it has to be in a consumer-friendly format. So think in layman's terms. It has to be easy for people to understand. So digging a little bit into the all service data set, so gross charges. So that's charged for an individual item or service as it shows up on your hospital's charge master, and that's absent any discount. So if there's any package pricing or anything like that, you want to have the actual gross charge on there. You need to include a discounted cash price. So that is if there's any, the package pricing could go in there, but then also if there's any patients walking up and if they don't have insurance, what would they have to pay for that procedure? The payer-specific negotiated rate, so that is all of your reimbursement, that's your negotiated, your allowed amounts that you have to have in there listed out by payer. De-identified minimum negotiated, so that's the lowest charge that a hospital has negotiated with all third-party payers. That does include Medicaid. That's your lowest charge. And then your de-identified maximum negotiated. So that's your highest charge that a hospital has negotiated with all third-party payers. So if you've got your Premera as the lowest and your United Healthcare is the highest, you need to list those out for each one of those services. And it has to be de-identified. So you have to say, this is Premera's charge and this is United Healthcare's contracted rate. So your all service data set, service bundle. So this is some additional guidance that CMS provided on a Q&A back on January 15th. And they indicate a little bit more, gave a little bit more information in regard to service bundles, that your service bundle should be provided by payer. This includes charges and the contractor reimbursement amounts. You do need to include inpatient DRGs and or per diems. Your outpatient surgical groups and your emergency case rates all should be included in your all service data set. And I do have the link down here to that FAQ. So when we hand out that slide deck, you'll get a little bit more information in there if you choose to dive in. So let's dig into a couple of FAQs, and I'm not going to read through all of this. I know there's a lot of information on here. So basically, what if the hospital does not provide a discount cash price? If the hospital doesn't have a discounted cash price, then you just have to post your gross charges. What about items associated without an associated HCPCS or CPT code? Do you have to list those? Yes, you do have to list all of those with the standard charge. So if you don't have a corresponding charge or diagnosis code, it is acceptable to leave the information blank, but they recommend that you should choose your own indicator to communicate to the public that no code is available. So there is a table 1 here on one of the documents that CMS provided that gives a really good depiction on how you can include that. If there is no HCPCS code or CPT code, NA was suggested, and a lot of people know that NA means that there is not a code associated with that, or there's not a data item associated with that, so that's pretty common, and that is something that that CMS does recommend. So if the hospital hasn't provided the service in the last 12 months, so that's some of the things that we look at when we look at price increases, for example, or cleaning up the charge master. Boy, we haven't done this service in over a year. Is it still relevant? CMS says, yes, you have to post it. So hospitals must post standard charges as applicable for each item or service with an established standard charge. So if you have it on your charge master, even though you have not provided this service in quite a long time, you still do need to include this in your all service data set. How should hospitals display charges for services that are based on severity of illness? Now, this is really common. The final rule does not limit hospitals from displaying additional clarifying information for patients. So in other words, you still got to put it on there, but it's good for you to indicate some more information on there. So for example, providing a base rate for each severity level within a DRG or other clarifying information to patients related to how a service package base rate may change. So you need to list out all the base rates. There is some examples in that last slide where that link was that indicates the table. There's some more examples in there on how you can list out your severity of illness based on the rates, and then you can provide that information to the patient or consumer, I guess I should say. So shoppable service requirements. So here's your second data file. So those must also be displayed prominently on a publicly available website. They've got to be free of charge, no login or password required. I should be able to, back to that colonoscopy example, I should be able to log into your website, pop that name in there, whether I know the CPT code or I'm just typing in the word, colonoscopy. It should be able to pull it up without me actually logging in or creating an account. Has to be searchable, like I mentioned in that last example, either by a billing code, maybe by payer or service description. We have to have that options or those options. A plain language description of each code, along with any applicable primary code used by the hospital, must be required, so that billing and accounting. So it's just one-to-one. If I'm pulling up the word colonoscopy, it should also pop up that code for me in addition to the charge for the service, so that I have all that information available to me. And then use an indicator when one or more of the CMS specified shoppable services are not offered. So that kind of goes to a couple slides back where I mentioned CMS is requiring 300 shoppable services to be on your file. But if you don't have 300 of them, then you can use one of the an indicator. And CMS is not pushing forward a required indicator at this time. Although, like I said, they did suggest NA. So you can put NA in there if you don't have that shoppable service of one of the 70 required by CMS, and that's perfectly fine. So some FAQs about the shoppable services. So what is a shoppable service? And CMS defines that as any service that can be scheduled by a healthcare consumer in advance. So some examples, we've got joint replacements, PT, hospital administration of medication, flu shots, infusions. These are things the patient can make appointments for, and they should be able to go online and shop for the cost of that service. What if a hospital doesn't provide? So back to that question I've talked about a couple of times, you can put an NA in there. So if you don't have 300 shoppable services, you need to indicate that. If you don't have any of the 70 CMS required shoppable services, then you need to indicate NA that service is not provided. But CMS does say that you must list as many shoppable services as provided and clearly indicate if you don't do one of the 70 CMS required. Okay, so a lot of questions came up during the Q&A. What if I'm using a price estimator? So I've already got this front-end process in place. We've got this bolt-on system. It's really robust. We're giving patients price estimates, and it's great. Can I use this in place of it? So as long as you provide estimates for as many of the 70 CMS specified shoppable services and as many of the additional hospital selected services that get you up to that 300, As long as the patient can obtain an estimate of the amount they will be obligated to pay, and as long as your estimator tool, so if you've got something that just your on staff, your internal folks use, you'll now want to look at how can I open this up to the rest of the world, has to be prominently displayed on the hospital's website and accessible to the public without charge. So there's a lot of organizations out there that do have that front end, and really it's best practice to be able to give an estimate to the patient so that they have that awareness when they're coming in for their visit. But usually you're not going to roll that out to the public. Well, this is something you'd have to do. So if you choose to use a price estimator in lieu of the searchable file and everything, you will have to open that up to the public. It has to be free to the public, and a lot of times these estimators will charge per transaction. So you got to think about that. And the patient should not have to register or provide any information, any personal identifying information or anything in order to get an estimate. Can we require, or can an organization require that insurance information be collected? Yes. Yes, you can require that. You can have that open for patients to fill that out. And honestly, it would be a good practice to do that because they're not going to get a very good estimate. They're going to get an estimate on what it would cost, but not based on their benefit level and where they're at with their deductible. So if they really want to have an estimate that makes sense to that patient, then you'd want to have those fields provided and available to the patient to fill out. And CMS says that that's perfectly fine. In the situation of a patient using a price estimator that is publicly available on a website, you can ask them to enter in insurance information so they can get a more customized estimate. Okay, so the CMS required 70 does consist of 4 standard categories, so we'll dig into that a little bit. So you've got to have your evaluation and management services. Some examples are psychotherapy, you got your new patient visit, your office consult, labs and pathology services, radiology services, medicine and surgery services, like I mentioned a couple slides ago, your joint replacement, we've got cervical spine fusion, endoscopy, things like that. Those are part of the services that CMS is requiring as part of your shoppable 70 that you need to have on there. So how do you select shoppable services? So here's a couple of tips. So first you start with the 70 CMS required services. So that's the first place that you want to start because those are the requirements. Indicate NA on any services or items that we don't actually provide at the hospital. If we're not going to provide it, we don't provide it, then we're going to put an NA on there. Report services commonly provided at the hospital to get to your 300. So this is where you're going to want to pull your usage report, your revenue and usage report, and you're going to want to see how many procedures do we do, and is that part of the shoppable services list? Can we add that to one of the shoppable services? Does it make sense? So pull out your popular ones first. Review reports at claim level, inpatient and outpatient, so you can take a look at the volumes and some common bundling items. Inpatient DRGs, start with the top cases by volume. Here's what you can do. You can identify and match the required shoppable services with the DRGs. So if you're providing one of the shoppable services on an inpatient basis, then that's one of the things you're going to want to pull because it's the more commonly more popular to get up to your 300. One example is vaginal deliveries. Professional code is a 59400, which is also a shoppable service. That's one of the required. Outpatient, review service bundles with labs, E&M services, see what's the most popular, see where your volume's at, and that's where you're going to list in part of your 300 so that you can get to that 300. So data reporting. So as you're pulling this information, there is some opportunity, some risk area, if you will. Your charge master has to be up to date and complete. It can't be missing any NDCs, any units of service, any drug codes. Another issue you may come across is your 835, 837 claim data may be incomplete or not available. So for some of those payers that accept paper claims or remit to you on an EFT and then a paper EOB, then you're not going to be able to pull that information in and compare those services and that reimbursement across the board. Consider payment information may not be available to split between your professional and your technical services. So it depends on the hospital informatics system that you have. So if you've got like an Epic where you can split out, you know, your pro fee, your HB with your PB, then you can do that and you can easily parse out where the payments go. But if you've got something more like a oh gosh, who combines it together? Maybe like a CPSI, or I believe a MedHost may have things combined. Your 1500 and your UB are going to be combined under the same account number. So you may want to think about incorporating distinct transaction codes. So one transaction code for a hospital payment, one transaction code for a professional payment. And that is going to take some setup, but I think it's going to save you some time in the long run, because this price transparency stuff isn't going away. And so getting yourself set up to be able to pull that out is going to be really helpful. And then honestly, it's going to help you when you look at reimbursement rates too, because if you have that split out as kind of a side bonus, you'll be able to see how you're being reimbursed for certain procedures, certain codes. Another issue you may run into is your contracts may be outdated or not readily available. So sometimes there's a contracting department, and this is pretty common, and I've run into this quite a bit in my past, where the contracts department work really closely with the payers, but not a lot of information trickles down to PFS. So your billers are doing their best and they're working these claims, and they're not really sure if they're getting the full allowable or really the contract rate, because they don't have access to those contracts. It's kind of on a need to know basis, which I don't necessarily agree with, but I also understand. So payer contracts, there's a lot of them and there's a lot of addendums, and so you just got to be aware that some of them may be outdated. So when you're setting up or when you're looking at doing your price transparency, it may also add a lot more work onto your plate if you start digging into those files and notice that they're kind of old. All right, so what is CMS doing? So back in December, and I was reading a bunch of articles, the thought is that CMS was not going to be going back and doing their own review of websites. So they were going to say, well, we're not going to dig into hospital websites. We're going to actually handle this on a complaint basis. So if the public complains about a hospital, then yeah, we'll go into their website and we'll take a look at what that tool is and see if it actually follows the rules that CMS has laid out. There has been some updates since then, and we'll get to that in just a minute. But basically, if you are found to be non-compliant, here's your kind of track that you will follow. Here's the road that you're going to go on. So a warning letter is going to be sent to any hospitals or any organizations that have been found as non-compliant. And non-compliant means either you don't have it set up at all, it's partially set up, or some of the links and things are broken. So you've done your best, but it's not all there. So maybe you've got your information in there as far as negotiated rates, minimums, maximums, all that stuff, but you don't have your payers attached to it. You would actually be found as not in compliance. So you're going to have 90 days to respond to your first notice. So CMS is going to send you a little letter, and they're going to say, hey, this is what we found. We're going to give you 90 days to turn that around. If they go back and they check in and there has not been any resolution to what they've put in their letter, then there's going to be a second notice. And this is a warning letter. And depending on the information that is missing or the level of non-compliance, it's possible that they may issue a corrective action plan. It could just be a warning letter. It could be directly to the corrective action plan. It depends on the article that you're reading, because CMS has provided all sorts of information out there and it kind of goes back and forth a little bit. My hope is that it's going to be a warning letter, but they may just push forward a corrective action plan. On the third notice, so if there has been no remediation from the corrective action plan, CMS is going to issue a monetary penalty to anybody that is non-compliant once you get to this stage of the game, okay? And that monetary non-compliant penalty, we'll talk about here in just a second, is $300 a day for non-compliance. But let's jump back up to this first bullet here. So remember when I mentioned that back in December, CMS said, yeah, we're just going to do it on a public complaint basis. Nope. They are now, they have indicated that they're officially proactively auditing websites. So they're going out and they're making sure that all the information is readily available. No, there is no requirement to log in, there is no cost, and that you can get all the information that is required easily and quickly by going onto a website. So as I mentioned, it is a $300 per day for non-compliance. Now I haven't seen if it's going to go back to, so say for example, you get to this point on step 3, they're imposing the monetary penalty. I have not read anywhere, but it's been about a week or so. I haven't read anywhere if they're going to go back to January 1st. Are they going to retro that, or is it going to start, excuse me, from the date of the third notice. They haven't really confirmed that, at least as far as I've read. So that's a little up in the air. And as far as I know, they haven't imposed any monetary penalties to any hospitals yet. But like I said, it's been about a week and these things change pretty quickly. So if as a hospital, you do get the monetary penalty, a hospital does have the right to appeal, and they can request an ALJ hearing, but it must be done within 30 days of the issuance of the penalty. So you got to get right on top of that stuff, which is kind of tricky because a lot of letters, I don't know about you guys, but in my experience, a lot of letters from CMS or the MACs go directly to the CFO, or they go directly to somebody that, it doesn't make any sense. Maybe your VP of HIM, and it's just a letter and they're not really sure what to do with it, and it sits on a desk. And so 30 days is a very short, kind of scary time frame. So we want to make sure that we're really on top of that and that everybody's kind of on the lookout for that CMS letterhead. CMS is not currently reporting any non-compliant hospitals on their public website. There was something else that they indicated as part of their action plan. If they found a hospital that was not in compliance and they went through the first warning letter and then they moved on to the action plan, at that point, they were going to list that non-compliant hospital on the public website so that consumers can see these hospitals are not complying with the requirement as laid forward from CMS, but they're not doing that. And the reason why is because they want to provide the hospitals an opportunity to respond to that action plan. They want to give them time to correct. And if they were to put the hospital's name on their public website, that could have a negative impact to that hospital, an unfair negative impact. And so they haven't said when they're going to start putting the hospital names on the public website. Right now, they're just getting as far as, we're going to issue that action plan once you get to this point, and we're going to give you time to respond to that action plan. I saw in Becker's Healthcare that the first round of warning letters were actually issued in April 2021. And since then, they've been moving a little more rapidly, where they're going in and they're looking at those websites and they're issuing more warning letters. And so CMS has gotten with the program, and they are reaching out and checking to see if we've got compliance. So here's our silver lining. Believe it or not. Now, revenue cycle, hospital, financial. I mean, we got to think of a silver lining for everything, right? As we try to navigate all of these changes from payers, all of these requirements from CMS. Really, at the end of the day, it means more work, right? But there is a silver lining to doing some of this work. So one of the things is, be patient with me here, guys, because I'm putting on I got my pom-poms, I'm putting on my little cheerleading outfit, because this is good stuff here. Trust me. So it's going to provide you an opportunity to address your CDM concerns. So like I mentioned before, in order to be compliant, you have to have all the information in your CDM, which is NDCs, units of service, revenue codes. Now, if you think about your CDM concerns, how many denials have you gotten, or how many things are sitting on your work queue for your charge master person to make those corrections? We got claims going out the door that have incorrect revenue codes, they're missing the unit of service, they have the wrong unit of service, getting denials for missing NDCs or invalid NDCs. You clean this up on the front end, not only is it going to get you in compliant with your price transparency, but it's also going to help you on the back end with billing. Claims aren't going to stop in your claim scrubber because it's missing information. Claims aren't going to deny because you don't have the right revenue code attached to that CPT. So it really is work. It's the juice is worth the squeeze, if you will, in doing this. It's also going to provide transparency to peer pricing. So there is some files that you can purchase, or software that you can purchase that gives you national averages and stuff like that. But it's nice to know what Joe Hospital down the street is actually charging for some of these procedures. And so this is going to give you information. So when you go in to try to do some of your price, when you start to increase your pricing on an annual basis or whenever you do it, that's going to give you a little bit more data so that you can look at your CDM, you can look at your services, and you can price it with a little bit more information in your pocket, which is always good. You'll be able to review claim data to find the most popular, to be able to put it on your shoppable services, and that could expose payment inconsistencies. So as I mentioned before, by creating that transaction code to split out your hospital from your pro fee, you're going to be able to see where some insurance companies are paying things a little different. So Insurance companies have adjudication systems, they have errors, they have updates, and so it's very possible, it's probable that you're not seeing consistent payments on some of these CPTs. And unless you have an external agency, or maybe you have a bolt-on system that's going to handle underpayments, if you don't have that, looking at your claim data from a simple high-level reporting in Excel, you're going to start to see some of these inconsistencies, and then you can question it. And that's when you call up that provider rep and you go, hey, I've noticed a 16% decrease in this procedure code reimbursement, and I didn't change anything in my contract. Like, what's up? So that's going to arm you with a little bit more information to try to get paid what you should be paid. You'll be able to quickly see denial trends by looking at your 835s. You're going to look at volumes. And really, this is also part of that denial management work that you need to do. You want to look at your 835s. You want to start pushing back and working with the departments to have them clean up the process on the front end. So this is going to give you the data that you need to also tackle some of those more difficult or more tedious denial management tasks. An increased sense of urgency with implementing time-saving workflows. So if you sit down and you realize, gosh, we're going to have to look through this charge master, we're going to have to manually look at some of these things on an annual basis, because remember, CMS is requiring that we have our charge masters up to date on an annual basis with that up to date or with that update date on the file, so that they know that it's the most current on there. So if you realize that this is going to take a lot of manual time, you might be able to push forward some of these initiatives that are going to be costly when you start talking about, well, now for price transparency, that adds another layer to the work that we're going to have to do. And I'm talking like your price estimators. If you've wanted to add more of your payers into an 835 rather than your paper remits, this is a good way to do it. You can go to your VP or CFO, say, hey, we've been wanting to implement 835s. I know there's a cost with my EDI clearinghouse system, but I think it's worth it because not only will I be able to save my cash posters time, but now we need it for price transparency. And backing up to that middle bullet there, we're going to need it for denials too. So it's kind of a win-win. Denial management or underpayment tools are only going to give you some fantastic reporting and additional reimbursement, but it's also going to, you'll also be able to use those reports when putting together your shoppable services for your price transparency requirement. And then at the end of the day, and this is all why we do it, is for the patient. It's going to increase patient satisfaction through the billing and self-pay process. So if your self-pay team now is able to have the conversation with an educated patient, a patient that knew the out-of-pocket, what their out-of-pocket would be for that scheduled service, that makes the self-pay rep, makes their job easier, it makes that conversation easier, and you're going to see probably increased patient payments because the patient will be prepared for it, maybe set up that prompt pay discount, set up those payment plans, and the patients are going to feel like they're more in the loop instead of that mystery at the end of the day where they get that EOB and it's more difficult than an escrow mortgage statement, right? So increased patient satisfaction is definitely a big win. Thank you so much for joining us. Hopefully you were able to pick up a nugget or two of information that you didn't already know. Have a great rest of your day. Thank you.